So, Dr. Anand has already dealt with the patient selection as well as target selection, so I will not deal with these. For simulation, the only tip is that when you are simulating, the FOV should include the entire chest, skin to skin. So that is one thing that has to be kept in mind, especially for bulky patients. And the patient's position should be very comfortable because these treatments are typically long. So the patient should be able to lie down in the planned position for nearly 20 to 30 minutes. So these are the steps in delineation. Every time when we are seeing any phase, any step in Sbrt, we should review the diagnostic imaging, the simulation imaging, compare them for any changes in the interim period, look at the number of lesions as well as the tumor location. I'll deal with the target delineation and the OAR delineation in this order. So for gross tumor volume, we know that the lung tumors are mobile tumors. So the true GTV estimation can be done only when the lesion is relatively stable, as in a breath hold scan, or if it's a 4DCT, a single phase of 4DCT. So that gives the true estimate of the volume of the lesion, because motion will create blurring artifacts and there will be larger inter-observer variation if we do not account for single phase treatments. So for delineation of gross tumor volume in lesions which are surrounded by the lung parenchyma on all sides, typically a pulmonary window is used with a window width of 1600 and a window level of -600, and include all the tumor speculations. Always look at the tumor in all the projections, because something that looks like a speculation in one of the projections may actually be a vessel which is touching the tumor. So that vessel does not need to be included per se. And lesions which have an interface with the mediastinum or the chest wall, typically a mediastinal window is used to correct the GTV in that area with a window width of 400 and a window level of -20. We can also see that when we compare the lung window and the mediastinal window, we will look at the discrepancy in the volumes. So the volume within the lung parenchyma should correspond with the lung window. The volume at the interfaces should correspond with the mediastinal window. And one should avoid inclusion of any adjacent vessels, atelectasis, or mediastinal or chest wall structures. If there are any suspicious pleural tags, typically type 2 tags where there's a soft tissue component at the pleural end, these tags should also be included as part of GTV. If the lesion is closer to the chest wall or close to the mediastinum, IV contrast may help delineate the lesion from these, also identify the vessels which are organs at risk. And also there may be sometimes for central tumors, there may be peribronchial tumors where atelectasis may also be present. So it is important to distinguish this atelectasis from the gross tumor volume. Sometimes PET may help. PET is usually not used for Sbrt because we typically select smaller lesions. We typically select lesions which are very well defined, but in certain situations, it may be useful. We don't have a CTV concept in Sbrt. Typically, the CTV is equal to GTV, and we assume that the microscopic disease would be taken care of with the intermediate doses. There is a concept of IGTV akin to the ITV in the conventional planning, where we look at the motion of the GTV in all dimensions and encompass all that motion and call it IGTV. So even if we are using DIBH, where we assume that the tumor is stable, there will be some residual motion. So that residual motion should also be encompassed while delineating or while generating the IGTV. Once the tumor size changes, on the right-hand panel, we can see that the IGTV volume also increases. So if you're using MIP projections or we are using multiple phased scans in target delineation, we have to take into account that we'll be treating more and more of normal tissue as we use the IGTV concept when we're using MIP projections. Usually, MIP projections are not good for lesions which are close to diaphragm or which are close to the mediastinum, because the interfaces will change. The relationship of the tumor with that interface will keep on changing with the different phases of respiration. The spine movement also is different when you're using MIP. So in those situations, for planning purposes, it is recommended that we use the average intensity projection. We mark the tumor on MIP, but we use the AIP for the rest of the planning process. Depending on the treatment planning technique or the motion management technique, the IGTV may vary. I've already talked about the IGTV using 4D CT as well as using breath hold. But even when we are using tracking or gating, additional 2 to 5 millimeter margin may be given to account for the uncertainties in reproducibility of breath pattern or any other position or any other uncertainties. So this is a delineation of the image where I have used two extreme phases. We can see that the tumor is moving more medial lateral and not towards the chest wall, although this is not an ideal scan for MIP kind of treatments, but here the chest wall movement was not as much as the tumor movement. So we have to make sure that if we are estimating the tumor on all of the respiratory phases, the MIP images corresponds to that, at least when we are starting out with the Sbrt program. And for patients with lower lobe tumors where the lesion is closer to the diaphragm, abdominal compression and DIBH may help to reduce this IGTV compared to the MIP projections. PTV typically will encompass this IGTV and also give an additional margin for setup errors. This should be determined by an institutional workflow and the setup conditions in that institution. Conventionally, 5 millimeter in all directions is recommended over IGTV, but this is, as I said, it is variable. If our institution does not have a lot of equipment where, or we are not certain of the treatment situations, a higher PTV margin may need to be given. In protons, usually PTV margin is not used for planning, but may be used to evaluate conformity. The organs at risk should always be drawn in axial planes of the primary planning data set. All the serial OARs within 5 centimeters craniocaudal extent of the PTV should be taken. But if you're using non-axial beams, even distant OARs may need to be delineated. All the parallel organs like lungs, liver, kidneys must be contoured in their entirety, even if the relative part of the OAR is close to the tumor is smaller, and nomenclature should be standardized. This is a standardization on the right-hand panel given by the Global Harmonization Group consensus published a couple of years back. So trachea is simple. Only take care that you also include the tracheal wall and the adventitia. And typically when you're contouring only trachea, we take the segment of trachea till 2 centimeters above the carina. The proximal bronchial tree is a very important structure in lung Sbrt. It includes the distal 2 centimeters of trachea, carina, as well as the main stem and lobar bronchi. On the right side, first, it is the right main stem bronchus. It gives the upper lobe bronchus and then continues as the intermediate bronchus. And this intermediate bronchus also gives rise to the middle lobe and lower lobe bronchi. On the left side, the main bronchus gives off the upper lobe bronchus and then also the lingular and lower lobe bronchi. So till the lobar bronchi, we have to delineate. But further segmental bronchi do not need to be delineated when we are drawing the proximal bronchial tree. We give, these are the delineations on one of our patients. And we give a 2 centimeter margin to this outline. And this is what is used to determine the definition of peripheral versus central tumors. All tumors which are outside this 2 centimeter envelope are called peripheral tumors. Those within, inside this envelope, but still 1 centimeter from this tracheobronchial tree are considered central, and those which are inside that 1 centimeter are called ultracentral tumors. I'll spend a minute on the brachial plexus. Although the delineation is best on an MRI, that too on a coronal projection, but we have to make do. We can at least be 3 to 5 millimeters certain regards its position on a proper CT scan with contrast. So usually it is used only for tumors of upper lobes, and only the ipsilateral brachial plexus will receive a significant dose enough to be spared. So it includes the spinal nerves exiting the neural foramina from the C4, C5 junction till T1, T2 junction. So it has 5 roots, And even if the entire brachial plexus is not drawn, at least what lies within 3 centimeter vicinity of the PTV should be drawn. So we know that from anterior to posterior, if we look at the axial projection, it is vein anteriorly, then artery, then nerve. Veins and arteries will pick up contrast, nerves will not. So for a contrast scan, whatever is lying posteriorly and superiorly to the vein artery complex will be the brachial plexus nerve complex. So here we can see on the coronal projection that this vessels and nerve complex will go over the first rib and under the clavicle, and we can easily distinguish this with practice. So roughly we can contour these positions on a coronal projection and then look at the vein artery nerve relationship on an axial projection to identify the brachial plexus. IV contrast is highly useful in this delineation. And for contouring the upper part, we know that it has 5 roots, as I said just now. So wherever there are neural foramina for the corresponding vertebrae, the part which is exiting the neural foramina and it is passing through the anterior and the middle scalene muscles, that is to be delineated. And wherever the neural foramina is not present, only the part between the scalene muscles is included. So you can start at the top for the first root, then go to the bottom for the second root, and use the intermediate 3 neural foramina for the rest of the contouring. So esophagus and spinal cord are fairly simple, but we should try to include the entire length, esophagus from the cricoid till GE junction. And for spinal cord, it is typically recommended that we delineate the spinal canal and not just the cord, because we are not usually using the MRI for spinal cord delineation. The lungs should be contoured separately as well as combined. Use lung windows, include all the inflated and collapsed lung, all the emphysematous area, but also include the small vessels which are extending beyond the hyla, but typically lung, hyla, GTV, and trachea, main bronchi are not included. Heart and pericardium also have to be included mostly for central tumors or ultracentral tumors, and this is given in the guidelines by RTOG as well, so this can be taken. The entire pericardium as well as the pericardial recesses should be included. Chest wall, ribs, and skin are simple, but all of these should be drawn. Chest wall, a 2 centimeter thickness around the lung is recommended to be included. Ribs only for Dmax, and a 3 to 5 millimeter just inside the body structure will help reduce the skin doses for exit and entry of the beams. Some work in progress that the Medanta group and we are doing for delineation of phrenic nerve and recurrent laryngeal nerves as well. That's all. Thank you.
Thank you, Dr. Shikha, for an excellent presentation and very, very useful. Especially, I mean, all of us are learning, of course. Sbrt is still, it's an evolving thing. So excellent. Thank you so much. And we'll take the questions at the end as decided by sir. So the next, I think, is online. Is it, Dr. Niranjan? Arun is present? Oh, hi. So